Madam, we are live now. Shall we start?
Yes. Let me wait.
Good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all in today's very important topic on current trends in endometriosis. And our guest speaker is Dr. Sonia Rani, madam. So it's our honor to introduce Madam. Madam did her MBBS, DGO, DNB, and FAMS. Madam is the consultant obstetrician and gynecologist and a fetal medicine specialist, FMF London. And Madam is the laparoscopic surgeon and attached with KIMS, Federal's Mother and Child Center, Hyderabad. So with this short introduction, I request Madam kindly take over the session. And meanwhile, I request all the participants for your active participation. And please drop your queries on the chat box of the Shieldconnect page. So once the talk will be over, we shall have a short discussion on these emerging topics. So thank you very much, Madam, once again for accepting our request to this medical session, and over to you for further proceedings. Thank you very much.
Yeah, can you share the PPT?
Ma'am, is it visible?
No, not yet. Yeah, now it is visible. Thank you.
Okay, ma'am.
A warm welcome to one and all. I'm Dr. Sonia Rani. I'm a consultant gynecologist and obstetrician practicing for the past 12 years at Hyderabad. Today, my topic is endometriosis. As we all know, this is a very enigmatic topic, and it requires a holistic approach to treat the patients. Lots of questions will be there from the patients, whether it is completely curable or not. Though we have many seniors with us who have been treating for the past few years, still it is an enigmatic topic and it requires many updates in this. Yeah, can we go to the next slide? This is a recurring disease, endometriosis, wherein it is not limited to a particular place. So it is it can be there in the ovaries, it can be there in the uterine system, fallopian tube, serosa, and entire pelvic peritoneal surface. And also it can also spread to the skin and the previous scars. As we know, after previous cesarean, there can be scar endometriomas. So what makes this so, why does it spread so much? What is the pathogenesis behind the endometriosis? Why is it such a recurring disease? So coming to the pathogenesis, just to brief out, it is mainly the immune system of the patient which decides whether a particular patient is susceptible to endometriosis or not. And reduced natural killer cell activity in the peritoneal fluid, dysfunction of the cellular immune system, and macrophages which actually engulf the foreign bodies, there might be dysfunction in that also. Elevated levels of growth factors and cytokines which help in the spread of this deposits, and progesterone resistance. This is one of the most important factor which might enhance the pathogenesis. Next slide. The chemokines and cytokine release, these are the important chemical substances which might be involved. Eicosanoids are one of the substances which might cause the activation of the pain pathway system. So the deposition of the lesions and their growth needs vascular supply, and their further invasion needs proteases, matrix metalloproteinases, and all these tissue modifying factors, and inflammation of the endothelial active system. These are the potential contributing factors for the vast lesions of endometriosis. Yeah, next slide. Angiogenesis. For any tissue that spreads, just as we know in cancers, wherein metastasis happens, even the endometriotic lesions do follow the same kind of pathogenesis. That is, angiogenesis is required for the further growth and spread of the lesions. So angiogenesis is one of the important survival requirements for endometriotic lesions. Just as in metastatic cells, there is an activation of endothelial cell system, breakdown of basement membrane, migration and proliferation of the endothelial cells, formation of blood vessels, that is neovascular, neogenesis, and all those things within the basement membrane. and thus the new blood vessel system will be formed, and it enhances the growth of the lesions. Next slide. The endometrial tissues which are ectopic, usually we have the endometrial tissue within the lining of the endometrium of the uterus. These can be deposited through the tubes into the peritoneal space, and they can also be the deposits on the surface of the ovaries, within the ovaries, and even bladder and bowel system also. So endometrium, which has well-developed paracrine pathways and intercellular communications, in addition to the various receptors, helps in angiogenesis, and this happens in each and every menstrual cycle. It is not just limited to 1 or 2 months or 3 months like that. The entire menstrual cycle, menstrual phase of the women is affected by endometriosis. Yeah, next slide. As I have already told, the growth factor involvement like endothelial growth factors, transform tissue growth factor alpha, beta, vascular endothelial growth factors. These are all the important factors which might be involved in the growth of the lesions. Those ectopic lesions which have deposited, they need certain growth factors, tissue modifying factors, and vascular supply for their survival and for the spread. Next slide. Angiogenesis. In the involvement of angiogenesis, in the process of angiogenesis, there are certain proteins called integrins, catherins, selectins, and certain immunoglobulin families which support the angiogenesis and helps in the survival of the endometrial deposits. Yeah, next slide. Matrix metalloproteinases. These are certain tissue modifying factors which enhance cell-to-cell interaction between the deposits. So that is how they attract new cells and helps the formation of deposits as per revised American Fertility Society staging. Certain deposits are classified as stage 1, 2, 3, and 4. So based on whether they are powder deposits or depending upon the color and size and depth of the deposits, all the pathogenesis lies behind this matrix metalloproteinases. Next slide. There has been studies which showed enhanced expression of matrix metalloproteins in the endometrial tissues. So they do contribute to the growth of the tissues. Next slide. So yeah, this till now we have learned what are the factors that enhance the spread of the disease from the disease per se. So what does the patient's immune system do with this? What limits the depth of the invasion? So such an intense inflammatory response and that is initiated by the patient's own immune system tends to contain the disease as much as possible with fibrosis. So as the fibrotic reaction is seen, we can see the change in color of the deposits. There can be some white colored boundary around the lesions. And in such cases, there may not be linear spread of the lesions, but there will be a depth spread of the lesions, which can be seen sometimes in case of bowel and bladder deposits. So the intense inflammatory response and fibrotic reaction that is seen in and around endometrial lesions, it helps in limits the spread. That is, a linear spread will not be there, but it limits the blood supply, it reduces the growth potential, and it tends to contain the disease. But the depth of the lesions might be there still. Next slide. Yeah, enhanced proliferation and increased ability to implant and survive. So this is the main pillar for the endometrial lesions to survive. And even genetic, there is some genetic background also for endometriotic lesions. And complementary DNA microarrays also have shown down regulation of the apoptosis, which is a tissue eliminating system in our body, and tumor suppressor genes. So the same pathway which we see in cancer cells also is shown to be in endometriotic lesions. And pain perception, what is the reason behind severe pain perception for the patients? Increased nerve fibers in the endometrium of the patients who have endometriosis. There is more sensitivity and more nerve supply, and that could be the reason for the pain perception, along with the icosanoids, which are the chemicals which are involved in pain perception. Yeah, next slide. How different are the endometriotic cells? Because usually the susceptibility of any cell to apoptosis makes it to get eliminated from the body, but endometriotic cells may not be susceptible. There can be decreased susceptibility to even medications. There can be certain hormones which may not actually eliminate the disease per se. And impaired sensitivity of endometriotic cells also contribute to implantation and growth at ectopic sites. So the apoptotic mechanism is also may not be functional in certain endometriotic lesions. Next slide. Next slide, please. Sahiti, can you give the next slide? Yeah. So the inhibition of the menstruation, which is important, as we all know, for any endometriotic patient, we decide whether a surgery has to be done or not, what kind of therapy has to be given. It has to be customized to every patient. It is the same therapy may not hold good for every patient. It depends upon the age of the patient, her fertility options, and whether she's just want only the pain relief and she doesn't need any fertility at all. These are the things which decide how the treatment goes on. Next slide. Recurrent endometriosis. Endometriosis recurrence is the rule. And why recurrence? It could be a new disease that is developing. It could be a residual or a persistent disease that has not been completely removed by previous surgery, or something that has not been treated medically. Then it can be a deep-seated disease also, wherein hormones may not act in such lesions. So in endometriosis, recurrence is the rule. Next slide, please. Typically in endometriotic patients, we see wherein patients may have twice or thrice laparoscopic surgeries, repeated lap surgeries for symptom relief. And in both symptomatic and asymptomatic patients, surgery followed by GnRH agonist therapy or complete knocking down of the ovaries may be the only mode of treatment. And usually we give it for first 6 months. Then later date, we'll again see whether the lesions have recurred or not through a second loop laparoscopy. And in the recent trials, there have been also laser evaporation, which has shown good results. So trials have been there which are comparing laparoscopic removal versus laser evaporation of the lesions. A 24-year-old unmarried woman presented with increasing dysmenorrhea with each cycles. Laparoscopy was done. It has shown a revised American Fertility Society stage 1. These are mild lesions. She was treated with laser evaporation, but she has symptoms again after 1 year of the surgery. So it is recurrence of symptoms. And pelvic examination has showed some tenderness in the pouch of Douglas. Ultrasound showed no endometrioma. Next slide. So what would be the management options in this patient? What are the possible things which we can do? We can give her progesterones because she's not tending for fertility now. She's an unmarried girl, not keen on conception. And we either give her a levonorgestrel intrauterine system, which is the progesterone releasing system, which works for 5 years. Or we can give a course of GnRH agonists. And then after the treatment is done, we can arrange for a repeat laparoscopy. Next slide. What could be the different options? So if there are symptoms as previously she has before surgery, there are certain trials which have shown that GnRH agonists for 6 months at a stretch would give very good results, wherein the ovaries will not be ovulating anymore. And the treatment should be at least for 6 months. On completion of the GnRH agonist, we can give her again cyclical combined hormone therapy with an add-back of estrogen also. Next slide. So now we have seen a case of a woman who doesn't want pregnancy. Now, next case is a 34-year-old married woman who is presenting with 3 years of infertility and she's keen on conceiving, but she has symptoms of dyspareunia and dysmenorrhea. She is ovulating every month, and male factor has been evaluated. This shows to be normal. On ultrasound, the findings are normal. Tubes are like ovaries are normal. There are no space occupying lesions in the ovary. Uterus seems to be normal, and Ovulation patterns also seems to be normal. So because she has symptoms of dysmenorrhea, pain is the symptom which might give a call for surgery. It's not just the lesions if you find and she is asymptomatic. The concerns for surgery should be whether pain is there or not for her, and whether there are any space occupying lesions are there or not, and whether she is keen on fertility or not. So all things should be catered with a laparoscopic surgery. On laparoscopy, it revealed normal tubes with the patency, and ovaries are also normal. The tube-ovarian relationship is still maintained. But there are extensive lesions. And as we all know, with whatever extensive surgery, with whatever skills, with whatever the seniority we have, endometriotic lesions tend to recur. Next slide, please. So there is the possibility of incomplete surgery, incomplete removal of the lesions. So as the tubes and ovaries are normal, we can give her the option of IUI immediately and give her ovulation induction drugs. Or if she is very much keen on treatment, on immediate conception, she can go for immediate IVF treatment. If there is if she has some time to take for fertility, she can be given a GnRH agonist therapy for 3 months, and then we can give her some months to conceive naturally. There are cases wherein women can conceive naturally, even though they have endometriosis. So the male factors are normal, ovulation is good, she has good quality eggs and all. So there are many cases wherein they conceive naturally, though they have endometriosis. And we can also give her progesterone therapy like Dinoges 2 mg daily for at least 3 to 6 months if she's not keen on conceiving. So it has to be customized on the patient's option, whether she's keen on conceiving or not. Next slide. So medical therapies may not increase the pregnancy rate. In endometriosis, the main concern for the patient would be pain than fertility. Then comes fertility. So surgery helps to cater for the pain, and the medical therapy also. There are certain situations where hormone therapy also may not control the pain symptoms. So this is one important thing which we should be able to counsel the patients. Even though there is some amount of endometriosis that is still left out after surgery, that can be taken over by prolonged progesterone therapy. And maybe this can be given up to 3 to 6 months of time. After the 6 months of time, we just do a repeat ultrasound, and then we can advise the couple to have an IUI or IVF as per their options. Next slide. Yeah, this is a case 3 wherein the woman is already fertile, already she's her family is completed. Here, pain is a concern for her. She's not keen on conceiving. She's not keen on her menstrual cycles. Whatever bothers her is the pain. She was diagnosed with endometriosis elsewhere, and she was treated with continuous progesterones for 9 months, as this is a line of option for any one of us. This reduced some of her pelvic pain and dyspareunia, but symptoms returned within a few months to their previous level. Examination revealed thickening and tenderness of the uterosacral ligaments. Yes, here comes the deep-seated disease, deep-seated endometriosis, deeply infiltrating endometriosis. That is a DIE category of RAFS. Ultrasound scan shows to be normal. So we tend to take her to laparoscopy, and we can see the nodules on scarring on the uterosacral ligaments. What would be the next option to treat her? Yeah, next slide. So as we have learned in the first initial slides, that certain deep-seated lesions can be non-hormone sensitive, or they may not act at all. They may not respond to the hormone therapy. However, gonadotropin hormone agonist you give, however, progesterone we give, they may not be responsive. So menstrual suppression may decrease the symptoms of dysmenorrhea. That is completely we knock down the ovaries. The optimal results for symptom control can be mainly by surgical excision of the implant areas. So long-term disease control can be mainly by completely stopping the menstrual cycles. That is, we create an artificial menopause situation for her. This could be the treatment option for this third case of patient. Yeah, next slide, please. Coming to the last case, a 24-year-old married woman presented with 2 years history of infertility. She's asymptomatic, ovulating, patent tubes, and there is no male factor. All features are fine, but her only concern is fertility. So many cycles have been done. Many ovulation induction cycles have been tried, for which they were unsuccessful. So what would you do before you take up for any next decision for IUI or IVF? Just we can do a diagnostic laparoscopy to check how is the system inside, to check whether there are deposits or anything there inside. Yeah. Next slide, please. So if there are no deposits, even if there are deposits, we can proceed with IUI. Or if there are heavy deposits, we can give her a 6 months course of GnRH agonist and with an add-back of progesterogens. And if the deposits are very much thick, if they are amenable to removal, we can do a laparoscopic destruction of the lesions. If the lesions are clear-cut seen on the laparoscopy, we remove the lesions. Then after surgery, 6 months or 6 months of GnRH agonist therapy. This holds for every case. So destruction of the lesions and hormone therapy holds for every case. But if the lesions are very minimal, if the size of the lesions are very just powdery deposits only, we can proceed, let them proceed to IUI or IVF as planned. Next slide, please. So endometriotic lesions, sometimes if they have been seen or if they are there on the ovarian capsule, we can remove those lesions, or we can cautery burn the lesions because they may later invade into the ovarian stroma and they create a thick walled capsule and then the cystic lesions with all the chocolate material. So those lesions should be typically laser evaporated or cauterized. Next slide. So the collections in the endometriotic cyst might get spilled up into the cavity, as we all know, wherein they cause a lot of adhesions between the tissues. So tube-ovarian relationship might be lost, and the bowel may be adherent to the post pouch of Douglas, and uterosacrals may be they may be sticky. All the adhesions might be seen inside the laparoscopic view. So always surgical destruction of the endometriotic lesions whenever we do a laparoscopy could help to some extent to symptom relief, for the symptom relief. Next slide. Any endometriomas, that is the ovarian tissues. What are the cases wherein we do a surgery for endometriomas? Endometriomas less than 4 centimeters do not need surgery prior to IVF. These are based on certain non-randomized trials. And as per RCOG, ESHRE and ASRM guidelines, treatment of endometriotic lesions should be done in infertile patients. At least we just go inside, see how the tube ovarian relationship is there, how the deposits are there any deposits. If you are planning for IVF, for the egg pickup, there can be some problem if the ovaries are displaced for oocyte pickup. So at least before proceeding to any IVF or ICSI, it would be better to do a diagnostic laparoscopy. Surgical treatment of endometriomas can result in decreased ovarian reserve, as we know, because there can be excision of the total cyst, and then the reserve, the leftover ovarian tissue might be very less, wherein the ovarian reserve might come down. So greater the cyst size, more would be the removal of the tissue and more would be the loss of the ovarian tissue. And surgery also has been shown to improve the response to gonadotropins for IVF. So what kind of surgery? It is not uniform to everyone. It is just, it depends upon the size of the lesions and the depth of the lesions. Next slide, please. Next slide, please. What are the available options? Levonorgestrel intrauterine system, that is a progesterone releasing hormone device, which works for 5 years, which induces amenorrhea after 1 year of the device. So this is the one best possible option wherein the woman is not keen on conceiving and she's mainly concerned about her pain. And aromatase inhibitors, letrozole, also might act. And Chinese herbal therapy has shown some studies, and wherein it decreases autoimmunity and inflammatory reactions that we see. And there are certain other chemicals and substances which might have a newer approach, that's progesterone antagonists, selective estrogen receptor modulators, and statins. There have been selective progesterone receptor modulators also, and estrogen receptor ligands and inflammatory modulators. Next slide. So we have the GnRH agonist as injectable therapy. we may have VEGF inhibitors also, and cell adhesion molecular inhibitors, and progesterone receptor modulators, and estrogen receptor modulators. This is a future. We don't have them now, but there have been many researches which have been conducted on this. Next slide. So ultrasound and MRI very much will help us. A good quality ultrasound will be enough to diagnose the lesions. Then it can be added with an MRI. In ultrasound, we can detect the tubo-ovarian relationship very much accurately. Ultrasound also helps us to know which side the lesions are there, or ovulatory patterns, the kind of the endometrium which she is having each cycle. And serum CA125 is not a specific marker for endometriosis. It can be a marker for ovarian cancers also. Any inflammation or any pathogenesis in the ovaries might elevate the serum CA125. And other inflammatory markers also have been there. And genomic and proteomic analysis also has been there. There has been genomics wherein we can detect whether a woman has a tendency to have the endometriotic pathogenesis or not. And there has also been analysis of the endometrial cell washings, wherein we can see the deposits of the cells. And based on the history and laparoscopic features also, we can diagnose whether, we can suspect whether a woman is having endometriosis or not. So any women, we ask first the menstrual complaints, whether she's having regular cycles or not, and whether there are any menstrual cramps or not. So based on the history, we should be at least suspicious whether she's having endometriosis. And then we can proceed to the proper investigations necessary for her. Next slide, please. Sometimes the women may not give any history, but only infertility may be her complaint. Even she might neglect the menstrual symptoms. So in that situation, it can be an incidental finding for us to see the endometriotic deposits on the ultrasound. So on laparoscopy, if we see any lesions, we do take a consent, prior consent, and we can also explain during the surgery also to the patient attenders that this is the picture, and we can destroy the lesions instead of just abandoning the procedure. Then to prevent the recurrence of symptoms, we have to go with the medical therapy as an add back after surgery, because surgery is just removes the existing lesions, but it is not the wholesome treatment. Surgery should be always backed up with hormone therapy. After surgery, how much time we have to wait before any artificial reproductive therapy is planned? Next slide. So in young women who are not keen on conception, who have regular ovulation patterns, no male factor, we can give a time of 6 months to 1 year. And in women who are more than 35 years of age, who are already aging with their eggs, and egg quality might be compromised. Apart from endometriosis, the other factors come into play. So it should be customized. It is not that every woman has to go for IUI, IVF immediately after surgery. It can be customized based on the patient's age, her AMH, and other factors also. Next slide, please. So in young women, after a reconstructive surgery, after a reconservative surgery, or after a laparoscopic surgery, so there is a risk of reactivation. That is, we all know endometriosis is a continuous process. So we should explain them the things that she should get pregnant as soon as possible, because pregnancy gives protection. In pregnancy, there will be no ovulation, no menstrual cycles, as we all know. So that gives some 9 months of protection. Pregnancy and delivery gives at least 1.5 years of protection from endometriotic lesions from reactivating. So this should be explained in detail to the patient and her attendants. Then based on her decision, we can plan to give GnRH agonist, that is leupride depot, at least for 6 months, 3.5 mg monthly once as a depot, or once in 3 months, that is 9 mg as a depot. Suppose if she's not keen, a second look laparoscopy is not mandatory, but it can be done after a proper ultrasound. Next slide, please. Chocolate cysts or the endometriotic cysts. Typically, endometriotic cysts are recurrent. So every menstrual cycle gathers more chocolate colored fluid, more endometriotic fluid, and the cyst tends to increase in size. So either laparoscopic cystectomy or ultrasound guided cyst aspiration can be done. Maybe that needs skill expertise. Laparoscopic cystectomy can be done if the cyst size is more than 5 centimeters. Ultrasound guided cyst aspiration is a tricky situation wherein we don't know all the bowels, everything might be adherent over there. It's not just a simple cyst. So it needs wide bore needle. All those things matter. So laparoscopic cystectomy would be preferred option. Next slide. And in case of ovarian endometriomas, the reserve also is a problem. So this also has to be explained to the patient before planning for surgery. So all the possible options has to be explained. Counseling and consent of the patient is one of the important criteria in dealing with endometriotic lesions. This is a specialty by itself. So endometriosis has to be explained, and they think that once surgery is done, yeah, doctor, already we got a surgery done with 6 months and now it is there again. So we should be able to counsel the patients regarding the what are the things that can happen even though surgery is done, even though hormone therapy has been given. Till you get your menopause, there are the chances for it to recur. The only thing is that it might take some 6 months time or 2 years time. That's it. But it can be a recurring thing. So in infertility management, certain pearls, surgery is important. And why? Because we want to know the tube ovarian relationship and the tubes are patent or not. And how is in case if we go for IVF, how is are there any deposits on the ovary, and whether ovary is accessible for oocyte pickup or not. Next slide. Next slide. Yeah, in case of infertility workup, this a simple algorithm. First, we check the ovarian reserve of the mother of the patients. Then, if it is compromised or low, if it is less than 1, then if there are any previous surgeries already done on her, is there anything that has caused decreased ovarian reserve? We check that, and if there is any lesions, then if there are no lesions on the ultrasound, if there are no cysts on ultrasound, we can suggest her IVF straight away. And it can be donor embryo or donor eggs or her own eggs if they are of good quality. Suppose if there are any lesions and any surgery has to be done, we give her a GnRH agonist therapy, and then we proceed for the IVF. Suppose if the AMH is normal, but additions are still present, then surgery might help in her to conceive naturally, because in surgery we can remove the lesions, we can restore the normal function, and then it can be a debulking kind of surgery, and then she can try for 6 months to 1 year to get pregnant, and then we can suggest her IVF. So in infertility workup, not just the lesions, the other functions of the patient also matters. The ovarian reserve, male factors, tubal factors, and how is she ovulating. This also matter. Next slide, please. What does the clinical evidence say in case of poor quality of the egg? So donor egg might help. So even the donor egg is given, it is the same whether it is an endometriotic patient or non-endometriotic patient. The quality of the donor egg matters, whether it implants and whether it grows properly or not. So in disease-free recipient, donor oocytes from healthy women produce better results than donor oocytes from women with endometriosis. So it is the quality of the egg that matters and not the endometrium. Next slide, please. Next slide, please. Molecular level, maybe to discuss, there can be certain factors like the egg quality will not be good, endometrium may not be good. So an egg has to fertilize, has to be fertilized properly, and after fertilization, it has to settle properly in the tube, in the fallopian tube, and then it has to migrate to the uterine milieu. And for the endometrium, it has to receive the embryo, and then it has to receive the and it has to contain the fetus. So there are two important factors which decide them. The oocyte has certain spindle apparatus which helps in proper migration, and the endometrium has one important component called pinopods or pinoprods, integrins. These are all again tissue proteins which help in implantation properly. So in endometriosis, there are evidence which say that this can be defective. So the quality of the egg and the endometrium also matter much in case of pregnancies. Yeah. So there have been studies. These are electron microscopic images which show the difference of the pinopod system in case of endometriotic women and in non-endometriotic women. How the system has been well integrated and intercellular matrix, everything has been in non-endometriotic women. Next slide. Next slide. This is the integrin expression in case of endometrium, which helps in proper implantation. Matrix metalloproteinases, these are important things. These are tissue proteins which helps in implantation, which helps to maintain the cell-to-cell interaction. So optimum levels of matrix metalloproteins helps in the penetration and invasion of the trophoblast in a regulated and controlled manner. So this is the this is how the developing fetus can be supported. So any defects in this matrix metalloproteins might be the cause for implantation failure. Next slide, please. So what is the unmet need of endometriosis? So we need to we have known a lot regarding endometriosis, but there are certain factors which we still don't know. Most of the factors which we have known, we have tried to modify them. The lesions, we see what we to do, and the cysts, we see what we have to do. And the reason behind endometriosis is ovulation and then formation of this cystic material and then destruction of the ovarian tissue and the surrounding pelvic system, uterine pelvic system. So we have somehow tried to knock down the menstrual cycles, make the women kind of menopausal, and then try to contain the disease. This is from what we have known. But there are certain things which we don't know yet. So there is still an unmet need for endometriosis, no matter how many researches have been done. So there is an urgent need to identify the markers. So next level is the genomics and proteomics. So wherein we have a genomic and proteomic profiling for our body system. We have a particular system which can identify whether we are susceptible to certain diseases or not. So the same thing has to be developed for endometriosis also. The genomic profile for endometriotic tendency. This could be the future. Proteomic diagnostic tests are there, and there are certain prophylactic measures. As we know, we have the progesterone add-back system. Sometimes we can give estrogen and progesterone combination also if the woman develops any flare-up symptoms of menopause. Next slide, please. So what else can we do regarding awareness of endometriosis? Conducting many questionnaire worldwide, conducting the seminars and questionnaires, and these questionnaires will help a woman to assess where does she stand, how severe her disease is. Even the questionnaire can be given to the doctors, then they can give their to respective patients. So, and even conducting the school health surveys, wherein the disease can be at the root level. So by the time the patient comes to us, it can be many years she has been not aware of the undergoing disease. So these are the important things which give us important awareness among the endometriosis. Next slide, please. So this is Thomas Cullen, previous slide. He's the one who has identified the lesions first. He has described the endometriotic glandular pattern and all those things. This is a hysteroscopic view of typical endometriotic lesions in initial phase. Next slide. These are very much superficial lesions. These are the powdery deposits in the vaginal fornix. Even with the speculum examination in the OPD also we can make it out. And with the digital examination, we can find out the thickened uterosacral ligaments. Next slide. Yeah, next slide, please. Yeah, these are the important persons, Roger Gilliman and Andrew Shelley, who have been the pioneers for GnRH agonists, for using GnRH agonists as a part of therapy for endometriosis. Next slide, please. What is the principal mechanism for GnRH agonists? It is it helps in treatment of the endometriosis by decreasing the estrogen levels in the uterine system, uterine and tubovarian system. So knocking down the complete estrogen hormone in the body, that is the main thing, at least in the uterine system. So there can be, because of this complete suppression of the estrogen system, estrogen hormone, there can be increase in the amount of FSH and LH. This can be prevented by giving prolonged progesterone support. Yeah, next slide, please. So hypoestrogenic state will be there, and it also has the benefits of treating the adenomyosis and endometriosis in women with GnRH agonists. So that is completely knocking down the ovaries, wherein there can be no ovulation, no estrogen. That is the main principle behind the treatment with GnRH agonists. Next slide, please. Yeah, next slide. Yeah, next slide. These are all again the reasons behind the use of GnRH agonist therapy. So also there have been studies that post-operative GnRH therapy will help to decrease the adhesion formation and reformation. And the inflammatory molecules that are present in the peritoneal fluid, they have also been shown to be in the down-regulated phase. Next slide. So how are the patients which respond with goserelin in the women with endometriomas? Next slide. Preoperative use of GnRH agonists prior to the surgery and prior to the ART therapy will help to contain the disease, will help to decrease in the size of the lesions and better responsiveness to the artificial reproductive techniques. So this is what has been observed. Next slide. Should we really treat endometriomas before going for ART? Yes, the study says yes. Next slide. Yeah, here also. Next slide. To conclude, endometriosis is not like whatever we know is very less, and still what has to be known is very much there out there. So there cannot be a complete treatment for this. Only thing is that we do a palliative or symptomatic treatment to the patient by decreasing the number of menstrual cycles. Either we tell her to get pregnant so that it gives some amount of protection against endometriosis, and the visible lesions has to be removed by surgery. And those who are keen on conception, they have to go for surgery, then add back therapy with GnRH agonists, and then that is for a period of 6 months, and then immediately the function of the ovary and the ovarian reserve has been shown to be good after this surgery and GnRH agonist therapy. Thank you.
Thank you very much, ma'am, for this nice presentation. Just give me 1 minute time, ma'am, to check the questions if any are there.
Yeah, okay.
Thank you very much. Madam, if you allow me, then we can take the questions.
Yeah, please.
So, ma'am, what will be the medical management in case of scar endometriosis?
Scar endometriosis, we see the depth of the lesions, how deep they are. First of all, we see on the ultrasound whether they are just limited to the skin or they have been gone through the entire layers of endometrium, through till the layers of the uterus. So in a previous cesarean, usually we see the scar endometriosis, because at the time of surgery, there can be some deposits in the layers of the skin and subcutaneous tissue, subcutaneous fat, rectus sheath and all. So the depth of the lesions also do matter. If the lesions are visible and they are more than 2 centimeters in size, or if they are really causing severe menstrual pain, then hormone therapy may not work. We can, if the lesions are very small, then we can give the hormone therapy. Typically, gross lesions has to be removed by surgery, in depth, in totality, and even it has to be uh, followed up with a proper biopsy report showing that the margins are free of endometriosis. That is how the complete therapy will be done.
Thank you very much, ma'am. Yes, one question is, ma'am, how this disease severity can be predicted based on this diagnosis?
Severity of the disease is mainly based on the number of cycles the woman is having. If she's already having a small lesion and she's going to have repeated menstrual cycles, then we can tell her that there can be like, you may have the lesions to be increasing in size. There can be just menstrual cramps. There can be dyspareunia, that is pain during intercourse. There can be, the severity of the lesions can be based on her symptoms. If she says that she's having severe pain and bleeding during her menstrual cycles and bleeding through the rectum, that is when she's passing motion, she has severe pain and bleeding, it means that it has almost involved the rectal system also. That is a very severe lesion. So that has in-depth invaded the rectal system, that is a bowel system. So based on the symptoms of the patient, whatever she says, whatever the symptoms she says, it's just menstrual cramps or the other things, we can decide.
Thank you. Thank you.
Next question.
Yes, ma'am, ma'am, as there is a chance for recurrence, so what is your opinion? How surgery helps in endometriosis, or what will be your primary approach to treat endometriosis in case of this medical management or surgery whenever you choose the appropriate options?
Surgery, I say, as per my like my seniors who have told me, as per my knowledge till now, surgery would be an option only if the patient says she has pain. Pain is the criteria, first criteria to take her for surgery. And next option would be she's having a lesion more than 5 centimeters of ovarian endometrioma, and that is gradually eating away the rest of the endometrial tissue, ovarian tissue, and wherein her ovarian reserve might come down. That is the situation wherein she's keen on fertility, wherein we can remove the lesions and then send her for IVF as soon as possible after giving 3 months of GnRH add-back therapy. So pain is the main thing that concerns for surgery.
Thank you very much, ma'am. So thank you very much, ma'am. I could not find any other question right now. If we have any, then we can forward it to your mail ID. So thank you very much, ma'am, once again for your valuable time and for discussing such an important topic, endometriosis, and your valuable opinion. So in future also, ma'am, we will look forward for some valuable session with you in some other topics as well. So thank you very much, madam. Once again, have a good day, ma'am.
Thank you. Thank you for your patient listening.